Hi, my name is Ashley and I am 703. This is my portfolio project for a geriatric patient and end of life conversation. For the sake of my patient privacy, we are going to refer to her as Rose and her husband as Bud. Just a quick little overview of Rose and Bud. I had met them previously when I first started clinical back in January. We saw her husband because he was having some mental decline. We were doing a dementia workup on him. They were that couple that always comes in together, does their appointments together. They're very cute, very sweet. He didn't have a lot of significant past medical history at all. Really, it was just like his mind had been going. His wife, however, Rose, who is my patient that we are going to talk about, she had type 2 diabetes. She had an arrhythmia that ended up needing an ablation. She had a mastectomy back in 2021 for breast cancer. She had, let me see what else she had. She had stage 3 kidney disease and COPD and hypertension. So for her, we had a lot more going on for her. Moreover, she was stable, and then about in the summer she had an arrhythmia that she could not get out of, so they tried to do a cardioversion, they tried to do all that, and it didn't work. So she went in for an ablation in June of 2023, and then when I saw her again is when we decided to have the end of life conversation. She presented to us 5 weeks after her ablation. She was complaining of lower extremity edema, shortness of breath, new dyspnea on exertion, and she had some new jaundice that came out of nowhere. So what we did for her was we did a full workup. She had been seeing cardiology and pulmonology. She has COPD. She's on an albuterol inhaler for that, but it was relatively controlled, so she didn't have like a daily maintenance. It was more of an albuterol, like as needed, which I thought was kind of weird, which is usually not the case for people with COPD, but I digress. And she was on Lasix and aldactone and spironolactone as far as diuretics for the edema per cardiology. She had a little bit of that prior to her ablation. So when she came into us, she had 2+ pitting edema in that left leg. She was 5 weeks post her ablation. As far as like feeling any flutters or anything like that, she was fine, but she had this worsening. She had a baseline of shortness of breath because of her COPD, but it was exacerbated. So we thought maybe that procedure when she got fluids and the ablation and now her heart we're in working order, it's going to take a little bit of time to figure out how to offload some of that extra fluid with the help of Lasix. Her Lasix was only given at night, so we changed that to BID. She was supposed to see cardiology in 3 days from our appointment, so we suggested she take Lasix BID, try to pull off some of that fluid. We called her at 24 hours and 48 hours to monitor her overall clinical picture, to make sure she wasn't hypotensive, making sure she wasn't lightheaded and dizzy and all those things. So the more concerning part of it was that she was jaundice. She had a total Bailey of 1.8. She was having some abdominal discomfort, some distension, some not good things. So this is where it's good to have a primary care doctor for a long period of time. So my preceptor has seen these patients for multiple years. And she said that her shortness of breath, they had always been concerned about that because, like, since she was diagnosed with her breast cancer, because they were concerned for secondary malignancy. So pulmonology had been doing scans once a year, every 6 months, depending on, how she presents. But her last scan was in March and nothing had shown. But they were only doing chest x-rays, which was limiting your view of everywhere else where there could be a malignancy. Like, just because you're having shortness of breath, that could be caused by, fluid building up in your belly because your liver is not working, which seems to be what was happening with her. And it's pushing up, it's causing you to have that shortness of breath, it's causing you to have worsening where you're dyspneic on exertion and you're having to sleep with your head elevated and all of these things. And so nobody had done additional scans to check the rest of her body for secondary malignancy. So that is what we did. That's how we started. So we did an extensive hepatic panel for her to see if anything else came up abnormal. We did a CBC, check her white count. We did a CT of literally like her entire body. What else did we do? Anyways, so we got all that stuff back. She went to see cardiology. They adjusted some of her diuretics to help offload some more of that fluid. And we saw her again in 2 weeks to review her new lab work and her imaging. Unfortunately, there was some more abnormal labs for her. There was a couple nodules that had shown up on these scans. There at the very base of her lung, there was a nodule that lit up. There was a nodule that lit up on her liver, and there was a nodule that lit up on her reproductive organs. So what we did next was we essentially had an end-of-life conversation with her because she's 82. What is it that she wanted to do? Did she want to progress into her care? Or did she want to talk palliative? Did she want to talk hospice? I mean, we don't know that they're cancerous. We suspect that they are because of her history, but it's not without reason to go in and do a biopsy if she wanted to. So when we brought Rose back, we looked at I used a conversation project diagram or conversation guideline to talk to her about it. I obviously had my primary care, my preceptor in there with me because she knows these people inside and out. So when we talked about it, she was interested in at least talking about palliative care. She did want to move forward and just make sure that it was cancer or not cancer. So she did want to move forward with biopsy. So we got her set up with pulmonology to do a biopsy of her lung rather than do her liver because she already had like a hit to her liver. We didn't want to shock her out. And the reproductive organ, she had an ovary, like one ovary left because she had a hysterectomy. So we just decided to go ahead and do the lung because she felt most comfortable with that, and so did pulmonology. So she went in and we did all that. Nevertheless, we went and had this conversation for her end of life. That way we knew what to expect after. Their family dynamic was a little different. She had mostly a chosen family. She did have biological children, but they live out west, and they don't have a lot of contact with them. Rosa and Bud really didn't talk about their relationship very much. It seemed to be kind of a soft subject, and I didn't want to pry, being that I don't know them very well. They do have contact with their children, but they have not seen them in a number of years. So their chosen family is their church family, and that is who they wanted to talk to. Their preacher, there was a couple ladies that they played cards with. And then obviously her husband was the other person that she wanted to tell everything to. There was a barrier there though, because Bud has mild cognitive dementia. So really appointing him as her proxy was not appropriate. He wanted to, of course, and he was very sweet and he was responsive through the whole entire conversation. However, he was having trouble with memory, so what we would talk about in one appointment, he would not remember in the next. So that's not really appropriate when you're trying to get somebody to be appointed to know what to do when you can't make decisions for yourself. So we had a conversation then. Do you want somebody in your church group to make those decisions? Is somebody comfortable enough to make those decisions for you? Or do we appoint a guardian if you don't want your children to be that? She said that she would be willing to have her oldest daughter be her proxy, but then we'd have to have a conversation with her daughter and see if she would be willing to do that. I did not have a conversation with her oldest daughter. Dr. Dyer did. Her daughter said that that was okay for major decisions, like if she was literally at her last breath, she would be there, but that she did not want to be involved in any of her decision making prior to literally end of life. So it was more appropriate for us to get a guardian, the guardianship set up for her for anything that would happen in an acute situation. Her daughter lived in Arizona, and she said that there was no way for her to like go back and forth and do all these things. Nevertheless, a barrier that a lot of people face. So for our patient, her goals for her end of life, she told me flat out, she was like, look, honey, I have had a lot of people, family and friends that have passed away since I have been living. And what I had noticed is that a lot of them did not have comfort and peace in their end time. And she was like, that is what I want. She was like, if it is my time, it is my time. She was a very religious lady. She said that she didn't want to go against what God's plan was for her. And if it was her time, that she just wanted to be pain-free if it was possible. So when we started going through all of the comprehensive like discussion points, so patient goals, her goal for her end of care is to be with her husband if he was still living, because he was older, to be with her husband, to have her spiritual leader be there by her side. She wanted to be comfortable and pain-free. So those were her 4 things. The interventions to do that, we had the conversation about CPR, DNR, full code. She said she wanted to be a DNR. In the state of Ohio, it's weird. You can choose to be a DNR with intubation or a DNR without intubation, which was a hard conversation to have with people when I worked in ICU. But she chose without intubation. She said that she would be okay with it in the event that it would be very short term and her long-term prognosis was okay. But if her long-term prognosis was still death, essentially, she did not want it. So we chose to do DNR with intubation. She did not want dialysis. She was okay with blood transfusions as long as it wasn't like a mass transfusion. We had that conversation because your liver helps you clot, and she was having liver involvement, and there was a nodule on her liver, and she had some other labs that were going a little wonky. So blood transfusion she was okay with. She did not want a feeding tube. She did not want to have like any major surgeries that would be long-term in healing. She was okay with IV fluids and antibiotics and something that like one presser to keep her blood pressure up. But she said, that was the beauty of like having that experience in ICU, that I could tell her that there is usually a progress with at least 3 before it really is hard to come back from. So she was agreeable to one presser for a short extended period of time, or for a short interval of time. And if she needed to be cardioverted because she had that arrhythmia in the past, she was okay with, but she did not want a defibrillator or anything implanted in her body to keep her alive. She is at the capacity to make all of her own decisions at this point. So we wanted to make sure that she had a living will and advance directives, a durable power of attorney, and get hooked up with a lawyer to make sure that her wishes are legally documented. She did have a little bit of concern about her other children, that if they were left to make decisions for her, she thinks that they would prolong her life and not, even though they don't have a good relationship, or maybe not even a good one, just she was worried that they would not fulfill her wishes. So we got her hooked up with information to make it legal and binding, and that way they would have to. As far as doing the palliative performance scale for her, she ended up being a 70% on that diagram. If I read it correctly, she was, let me pull it up. She was at the 70% of, she was able to still do the things like live her life to her regular ADLs, with just a little bit of need of help. So I'm looking at it here. She was at 70%. She had a reduced ambulation secondary to her dyspnea and exertion and her shortness of breath. Her activity level, she couldn't work. She was 82. She was retired. Her normal household chores were a little bit difficult, impacted by her shortness of breath. She needed occasional assistance moving around, but not much. She didn't really use a walker. She was walking independently, but she would have to stop and take a breath, whatever. She was at full level of consciousness. So it estimated her median survival days as 145. And, or to be determined, depending on how everything goes. I think I'm reading that correctly. It's kind of hard to tell. And then for the Karnofsky scale, I think she also scored 70% on that, if I remember correctly. I'm just pulling this up to have like a legitimate reference. Yes, so she was unable to work because of her age and her disabilities. She was able to live at home and care for herself for most of her personal needs. And so she cares for herself, unable to carry on normal activity or active work secondary to one of her comorbidities, which is the dyspnea and exertion, COPD exacerbation, and essentially fluid overload. So those were kind of hard to explain to her in depth, but overall, it was a good conversation. It's a hard conversation. It's not one that we like to have, but it's important to have. And I think now that I've seen her after that, she is declining in her health, and she has just thanked us head over feet about getting everything squared away that way, that when her time is here, that her husband can be taken care of, since she is his primary care, that her children don't have to make decisions that they are not prepared or don't essentially want to make. So, yep, that is the story of Rose.